Thank you once again. We are here to talk about a very, very important topic on suicide. We have with us Dr. Ennio Ammendola. I hope I pronounce it correctly.
Good.
He's a postdoctoral scholar of stress, trauma, and resilience at the Ohio State University in Columbus. Conducts a lot of research with veterans, first responders, and other adults dealing with mental health issues and suicidal thoughts. Now, I have trained under Dr. Ennio, and he has come to India once to train us formally in REBT counseling. So he is extremely known to talk about suicide and suicide issues. He's received his MA in clinical and community psychology from Italy in 2002 and has completed his master's and PhD from Fordham University in New York. So Dr. Ennio has been also a faculty trainer of the REBT, or the Albert Ellis Institute in New York. And over the past 20 years, he has completed several professional trainings in cognitive behavioral therapy and dialectal behavioral therapy, family therapy as well. So Doctor, going on to you, thank you so much for being a part of this. It's a most important cause. We've seen a lot of rates of suicide going up during the COVID pandemic. Thank you so much for being here with us.
Thank you for having me. Please call me Ennio. But thank you for having me. I'm very happy to be with you. You know how much I love India. I have been there. I will return as soon as I can. And I'm always very sensitive with everything that's going on in India. And things have changed lately. It's a pandemic. And it comes with a lot of psychological, psychiatric, and mental health consequences. So I think it is very great. It's great to have this interaction, because my intention is to really reach everyone, to make sure that people understand what we are saying. So we are going to use simple terms, and as much as I can, based on my experience, to give you some strategy.
Thank you so much.
What to do.
I'm just going to jump into our first question about, a lot of times people come to us with general sadness. So I want to just bring about the differentiation between general sadness and a depression. Is the depression more worrisome? Because sometimes people are not able to distinguish between the two.
Yes. Not only they are not able to distinguish between the two, but a lot of times you work with clients that they have a different understanding of the wording, and they have a different understanding of the emotions. And at times you work with clients who do not have an emotional vocabulary. So sometimes they can use a sadness, but they don't intend sadness. They intend like some kind of major depression or something that is serious. Or even when they think about suicide and they have a plan, they can still tell you, I feel sad. What to do in those cases? I think that it is important to do a good assessment. And the assessment really needs to focus on how do you function as a person, okay? What I like and I do, and it's not that I recommend things, but I'm sharing with you what has been very helpful with me, is that when I talk about emotions, I always make the emotions on some kind of a dimensional numbers, a metric system that goes from 1 to 10. And then I kind of help clients, first of all, to find out what is a baseline. So I almost talk to clients and I say, from 1 to 10, 10 is the worst of the depression, which means you really feel down. You isolate yourself, you stay all day home, you don't go out, you don't see your friends, you feel very depressed. And 1 is like, okay, I'm functional, I can go out. I ask clients, what's the baseline? What do you usually function? What is the number that puts you at risk right after that? Some of them, they will tell you, oh, until I get to 5, I'm okay. And then after 5, I have a problem. Some others, they tell you I'm a 7. So I say that it's very important when we think about emotions to think about that in a dimensional way, from 1 to 10. Then you want to highlight what's your baseline. And then the understanding is that we make a difference. If you see the tradition, rational emotive behavioral therapy, RBT, you are trained, I am trained. We make a difference between unhealthy negative emotion and healthy negative
Right.
emotion. So we have anxiety and concern, depression and sadness. And the way I apply this principle, because basically that's the way I work, is that I tell them, once you get to the number that doesn't work for you, then it's a little bit more the sadness. Then it becomes something that we need to figure out what it is. We can call it depression, we can call it major depressive disorder.
Right.
But what has helped me is that they need to understand. And as a clinician, I make sure that my understanding of emotions is your understanding of emotion. We need to make sure when we talk about emotions that we talk about the same thing. What is sadness
Right.
for me is sadness for you. What is depression for me is depression from you. Otherwise, we are going to mix emotions and we don't understand each other.
And Dr. Ennio, it's very difficult sometimes for teenagers to express this range that you were talking about. So, is there a way that we can help them identify, especially for parents, because they probably dismiss it as a phase of sadness, especially in COVID.
Yeah, COVID has changed things. There was an interesting editorial on the New York Times a month ago that said that COVID has almost radicalized everything. Everything has become extreme. And so you went to total silence. We don't talk to each other anymore. Total social isolation, total emotional isolation. We're lonely because we live in a lonely century. But the COVID really has put us apart. Now, you can't give up as a parent or as a clinician. You need somehow try to reach out. And what would you do if they are not really, mostly the teenagers, that they say, oh my God, I'm wasting my time. I'm talking to you. I can't stand you anymore as a clinician. My mom told me I have to come here. My parents told me I have to come here. Nothing is
Right.
wrong with me. Everything is wrong with you. Sometimes I have an intro and I say, you are going to stay here for 30, 45 minutes. I'm going to stay here for 35 minutes. I have to be in the room with you. Now we can really decide to waste this 45 minutes because I'm wasting my time. You are going to waste your time. Or let's negotiate. Can you give me
Right.
10 minutes? Can you give me 15 minutes when somehow you pay attention to what I'm trying to say? Then I go on the emotions. If they don't give me an emotion in particular, then sometime what I use something that has worked with teenagers. I say, do you have a favorite song? Do you have a song that somehow describes how you are feeling? Is there any
Okay.
movie in particular that gives me a sense of what you are going through? And sometimes I'm able to talk to them. And if they give me a song, then I go and check the lyrics. Maybe even when I'm in session, I go through the lyrics. And if it's a sad song, I'm like, oh my God, I try to give some narrative. If it's a movie that I know, the new generation, most of them I don't know. But I'm like, oh, okay, what is this about? Why does it describe you are? Why you are going through this? And you have to find some kind of leverage. Sometimes I use, these faces with the
Yep.
emotions that they
Yep.
give you a
Yep.
name? And sometimes I try to say, okay, you don't want to talk to me. You are here. You think that you're wasting your time. Could you at least for 3 seconds pay attention to me and point to one of the faces that somehow describes how you are feeling? I don't give up, that's for
Yeah.
sure. I try to negotiate my time with them.
So moving from this topic, how does one identify the symptoms of suicide or, suicidal thoughts from the people which are living with them? Are there any indicators? Because sometimes post a suicide episode, parents are in shock and denial.
Now, the indicators, they come with observations. If you live with someone, you have direct observation of the person. And so you are able to see changes. You are able to see what is happening in the person.
Right.
As a clinician, so as a therapist, a mental health professional, you see them sometimes on a weekly basis, and you see a degree of change that you don't really know how sudden happened, how fast it happened. But if we really have to recommend something, if you live with this person or you have those person around, you have to become very, very careful and in paying attention if there are changes. My experience is that people perceive time in a different way when they are at risk of suicide. They don't have enough time. And so I have noticed that sometimes, well, let me give you an example. Sometimes your family members, that were those who were a joy at the party, were always extroverted, were always talking. Now suddenly they don't engage anymore socially. They don't
Right.
express the way they are feeling anymore. They don't call their friends anymore. They don't connect with other people anymore. Spend a lot of time in their room. They have very short sentences. Even if when they talk to you, they use very, like in 30 seconds, they're done with you.
Right.
And another thing that is very, very important is, and I learned this from Dr. Di Giuseppe, who is my mentor, the man who he taught me everything I know in psychology. You know him. He always say, "Ennio, pay attention to the tone of the voice." People, clients, at risk of suicide, or that they have, that they really feel this like major depressive mood that comes to them, they tend to be monotone. They tend to be
Okay.
very, you don't see those pitches in the word when they talk to you. And so if you see all those changes, if you see a lot of isolation, if you see that they don't belong anymore, if you see that they feel that they are a burden, if they feel or they share somehow with you that they are not able to find a solution to everything is going on, those are the things that you want to pay attention. You want to pay attention to the warning signs. You want to pay attention to things that you have never seen before.
Okay.
That will give you an indication.
And so this is in terms of behavior change that you mentioned. You also mentioned the emotional tone remains the same. There's not much fluctuation. In terms of the thoughts, are there any particular thoughts that we can identify which may indicate suicide?
Now, the thought as a quality that you can deny. It becomes, some people call it irrational, some people call it dysfunctional, some people call negative. The thought is related to, I can't live this life anymore. This is too much for me. I can't stand what's going on anymore. I must find a solution. Suicide becomes the solution to all my problems. This is too much for me. No one loves me. I'm going to be by myself for the rest of my life, and I don't want to live like this. The thought is negatively charged. And most of the time, there is a connection between this negative thought, which is a lot of pessimism, hopelessness, helplessness. I would never make these. There is not enough time for me. If I take medication are not working. Therapy is not working. Some people don't want to wait when therapy starts working. And so you got this negative thought that translate automatically in those dysfunctional behaviors, sometimes avoidance. They don't do things. They
Right.
start doing things. They used to go to, I don't know, the gym. Now they can't go anymore because of the COVID. They don't do physical activity anymore, which then translates automatically in the presence of negative emotions, because we know that the emotion is very related to what you keep telling yourself. And if you keep telling yourself, or you give yourself negative messages, then you make yourself feeling even more depressed. The
Okay.
progression that I teach to clients, I've been lucky enough professionally to work in different settings. I worked a lot in outpatient, inpatient. I'm still working in an inpatient unit. And the idea is that when I run the group, I take patients, I call patients because it's in the hospital, and I teach them the progression that they see. And I say, you go from sadness, you start feeling depressed, then there is a major depressive disorder, then there is despair, then there is a suicidal ideation, then you start to develop a suicidal plan, and then eventually there is a suicidal attempt. I like to educate them about this progression. And that's
Okay.
what happens, and that's what I think we have to be very sensitive to and attend when the change is happening. It's almost like a domino effect.
Right.
Try to intervene the first or second piece so we avoid the other piece to go down.
Right. And so, in terms of teenagers, we see a lot of self-mutilating behavior. We see them cutting, and often we have parents saying that, she got angry or he got angry, and this is what happened. Would you also call that as an attempt of suicide?
If you look at the research on this, there's a lot of research on what we define NSSI, non-suicidal self-injury.
Yes.
Cutting, hitting, biting, burning yourself. when there is in the presence of the phenomenon of non-suicidal self-injury, the fact that there is no suicidal means that there is no intention that I want to kill myself.
Okay.
So, but some research shows that even if there is no intention, at times they can work as a predictor
Right.
towards a suicidal ideation and eventually suicide attempt. And that's one category. So even though, and you said it correctly as always, that even if we are in the presence of non-suicidal self-injurious behavior, the research clearly shows that most of them, between 66 and 81%, they do it for emotional regulation.
Okay.
Or because they want to avoid an aversive affect mode. Or so if you think about the emotional dysregulation, then automatically you know that the emotional dysregulation is what activates people, and sometimes they think that they don't have the intention of wanting to kill themselves or wanting to die by suicide, but sometimes they cut so deep that they require stitches.
Right.
Or the combination, oh, before doing this, I was drinking or I was using drugs, which can make you eventually more disinhibited. And then you know what happened. And that's one category. Then we have the general, as you mentioned, the self-injurious behavior, or what we call the DSH, which is the deliberate self-harm, where you already have a component of intentionality, of intent, that I really want to do this and I am going to do this because eventually I want to die by suicide. So in the big schema, I always say if we want to give a frame of reference to all of these, we need to be careful because research shows that even when there is no intention and there is a self-injurious behavior, potentially it can be a predictor. Moving on and then developing suicidal ideation and suicidal attempt, which means we have to take it seriously, but we also have to always ask at the beginning, have you engaged in this behavior because you want to kill yourself? Do you want to die by suicide? And so do an assessment with the intention on wanting to die by suicide. But if it is a prolonged, if they engage for years, and we know that they do for emotional dysregulation, and you are dealing with someone as emotional dysregulation as a base, then I think we have to be careful.
Okay, and so how does one deal with that? So once you identify it, what do we, how does one handle the patient?
The idea is why they do that. There are several theories. In the past, you used to say, okay, that's not good for you, don't do that, stop. Come on.
That's not good.
We're all engaged in some dysfunction, behavior. I've tried to stop eating Nutella for all my life, which somehow it will become dysfunctional, but I've never been able to be successful. So the idea is not just to stop. The idea is that we kind of need to provide them with a different set of skills that they are going to replace. So I am going to teach you something that eventually is still going to help you with your emotional dysregulation. But instead of cutting yourself, biting or burning your skin, then maybe, and DBT is very good in this dialectical behavioral therapy, is give you some skills like emotional regulation skills, breathing exercise, look around and name 5 objects. There are a lot of exercises, but the main idea is, first of all, don't criminalize, because the idea of the perception is that they are doing the best they know.
Okay.
And they are going through a lot of emotional turmoil and problems. So they're doing the best they know. We don't criminalize it. We don't point the finger all the time. But then at the second phase, as you asked me the question, to be very direct and answer your question, it is they need a different set of skills that is going to help them with dealing with the emotional regulation. We know dialectical behavioral therapy does a good job. We have a very good data also for cognitive behavioral therapy, mentalization-based therapy, and there are good books out there that they could help.
And how often do you think, these acts of suicide or threats of suicide have been taken seriously? Because from my experience, I think because of the lack of psychoeducation, often we are not able to save the client or the patient.
The question is really comes down, do you take seriously when they say, I want to kill myself, or I've been thinking about wanting to kill myself, or, yesterday was the first time I thought about suicide, or that maybe it was going to be the solution to all my problems. problems. When you have isolated case and when you have clients that never made those remarks, then we have a tendency, even as a mental health profession, to take them seriously, to say, oh
Right.
my God, there is a change in the picture. So we actually, we need to do something here because something has changed.
Right.
The big concern is when you work with the same clients over and over and over, and they have a way of presenting information that some will call, that now we are debating about this, this term, which is like they tend to manipulate, they tend to
Oh,
influence. I
right.
like the more influencing some reaction, where they could use this idea of thinking about suicide and wanting to let you know that they are thinking about suicide because somehow there is a second gain, or they want to influence you to have more attention. Basically, I tell you the truth. I spend 90% of my time in working with clients at risk of suicide. I take any statement seriously and I engage anytime they talk to me. Because even if you have someone who wants to influence you and is using suicide over and over and over, I eventually am going to help them to
Right.
establish that there are different way of having attention, or there are a different way that people can pay attention to you. And once again, we go to what we said before, teaching a different set of skills that if you are in need of help, of attention, you can ask in a different way. But in all honesty, I always take seriously, because a lot of times you have work with clients that they use, like they tend to influence you anytime they use a, oh, I've been thinking about suicide. I think that suicide potential is going to be the solution to my problems. And what happens is that suddenly they have a trigger, something happens to them that is
Right.
immediate. You have no idea how many patients I have on the unit that they come after breakups or romantic breakups,
Yes.
separation, divorce, and they activate themselves in a second and they end up on an inpatient unit. They say, oh my God, what happened to me? I'm going to be by myself for the rest of my life. I invested 20 years in this relationship. She or he took all my money and then finally doesn't love me anymore because she or he did everything he wanted to do. So what do you do in that case? You don't take it seriously because you kept saying the same thing like for 20 years. No, there is a trigger that is immediate and there is something that is activating you emotionally. That's what I pay attention. I think that the trigger is very important, but I am serious when someone tells me I have been thinking about killing myself.
So once you've identified the trigger, and like you said, there are coping strategies that need to be taught to somebody. Uh, can you highlight specifically, like you did some time back, but some more detail on some other strategies that we can help, maybe not as a practitioner, but even at home? Uh, is that possible at all, or they need to be taken seriously, as you said, and then taken to a psychologist?
Yes, there is one question that I ask, and that I think, and I hope that this one becomes really almost like universally used. And I know that this is within the traditional dialectical behavior therapy, and even REBT. It's, what kind of problem are you trying to solve if you kill yourself? I would say that I start most of my sessions when they tell me, Ennio, I try to kill myself, and I attempted suicide, and I want to die, and I can't take this life anymore. I'm like, okay, let's talk about this. What kind of problem are you trying to solve? And that's when you start a narrative from, and if they tell you something. That's a scenario number one.
Right.
Scenario number two is you want to observe what's going on in front of you. You want to see the changes in the person. And you want to say, if you really want to engage someone, I say, I haven't noticed for the past 2 or 3 weeks that you didn't go out with your friends. What is happening? Is anything bothering you? I'm right here for you. Can I help you? You want to make any approach in a very collaborative way.
Okay.
You don't want to be like pointing the finger, something is wrong with you. You didn't leave your room for 3 weeks. Let's run to the psychology, the therapist, I know what's going on with you. No, you want to engage the person in a collaborative way, and you want to try to understand what's going on, why you see the changes. What are the things to pay attention to? Sleeping patterns, because those are very, very important. Sense of connection, as we did before. Social isolation. They start telling you, oh, I don't want to live anymore. I feel I'm a burden. I don't belong anymore. There's a lot of very good research by Thomas Joyner, Dr. Thomas Joyner, who's an amazing suicidologist that does this kind of research. And he clearly shows that, and I see these anytime I have an interview, almost on a daily basis, they tell me, Ennio, I'm a burden to my family, to my boyfriend, to my girlfriend, to my wife, to my husband, to my partner. And all those changes, they happen because most of the time there was a trigger that was there and activated them. And so you want to ask, what happened to you? What has changed in the last 5 hours, 2 hours, or the last day that, activated all this kind of reaction?
Okay. So I think emphasizing here on the trigger and the coping mechanism, I think is very important. And how would you suggest a family member can, approach this person who is suffering or dealing with these thoughts?
One, understand what's going on, okay? Even if you don't like what's going on. It's not about you. Really, it's not about you. You are not so important that things must go the way you want them to, because this is totally irrational.
Right.
You want to observe. You want to understand what's going on. You want to validate the pain that the other person is going through. So when you have a conversation and when you approach someone, don't go right away to a problem solution mode. Don't go right away, we do this, we do this, we do this, because it's going to help you. Without even asking, what's going on with you? How are you feeling these days? What happened? Can I do anything in order to help you? Did it happen before? Do you have someone that you can rely on? Are you talking to your friends about this? Is there anyone in the family that you feel more comfortable talking to if you don't want to talk to me? I just want to let you know that we are very close to you, that everything you need, we are here for you. That's engaging someone in a very collaborative way, instead of jumping in a problem-solving mode and you want the outcome and you want to fix the problem right away. You can't fix the problem. You need to understand first. And we are in this together. And I always keep saying, this is a very collaborative way of doing the work, basically. David Jobs, who is at the Catholic University in Washington, he really has developed an approach on this collaborative way of engaging, in his case, patients or clients, but even family members. The idea is, we are in this together, let's figure out what's going on. And I will give you my unconditional support. But if you jump in a very judgmental way, you go back to the famous stigma that we will talk later. So doesn't work.
And I think when you were talking all these statements or the questions that you were asking, I think what really came out standing to me was the compassion that was coming out in the words, and like you said, it's a collaborative way. Is there any correlation between depression and suicide? And what are the other illnesses, mental health illnesses associated with suicide? So of course, we know depression is one of them. What are your thoughts on that?
Yeah, depression is the most common one, and it always pops up like the main one. And there are some clinicians that unfortunately only make the correlation between the depression and suicide, and then they think, which is not supported by research, that if I help you with your depression, then automatically your suicidality, or when you heal yourself, it tends to decrease. It doesn't really work like this. We know that 90% of the clients can be diagnosed with mental illness or have some kind of a mental disorder. And some people say, okay, but what do we do with the other 10%?
Right.
The other 10% for some clinicians or some clinical suicidologists who do a lot of research in this field, they say that the other 10%, it's because they have some kind of subcategories of a mental disorder. Maybe it's less intense, less frequent. But depression, it really always comes up as the most common one. Now, if you really think of depression and you think of the manifestation of depression, or what characterizes depression, then you have the recipe of not only of the intervention, but then you have the magic recipe where you start dealing with hopelessness.
Right.
And we know that there is a lot of research done by Beck, Anthony Scioli, great. He did really an amazing work. He was at the University of Rhode Island. I don't know if he moved. He does really a great work on hope, helplessness, no one can help me, impulsivity, suicidal ideation, thoughts of death. And so
Right.
just the depression itself comes with everything. Then you got the impulsivity, the hostility. But even if we talk about depression, remember, this is a complex issue. It's a complex topic, mostly even the correlation. And we know that when we talk about suicide, we talk about something that by definition is a multifactorial, which means there are several factors. And this is on a clinical point of view. When we think about, if you do this work long enough, patient, inpatient, community-based, not all of clients who come to you are depressed, and are those who tell you, I want to kill myself. And so this idea that anyone who makes a statement, I want to kill myself, is by definition 100% unconditionally and absolutely depressed, we have to slow down a little bit, because there are also other conditions such as anxiety. I have had several clients on the unit having panic attacks, not able to manage their anxiety. Another condition that I think we didn't pay enough attention is obsessive compulsive disorder.
Right.
I have worked with a lot of clients where there is this obsession, this rumination, on and on and on and on, and the brain never gets off, and they can't deal anymore. And then saying, I think that killing myself is the only solution. And then you have trauma, post-traumatic stress disorder. Post-traumatic stress disorder is huge. Like the great job that they are doing in Ohio, when I'm privileged to go and work with them for 2 years as a postdoc, the idea in the research that they are doing is amazing. It is clear that the consequences of trauma then leads a lot of people to generate suicidal ideation. And then you have a psychosis, schizophrenia. And the one that really, I tell you the truth, because sometimes I talk to colleagues or when I'm by myself, I think the one that really that puts me on my toes and like in alert is when people hear voices.
Right.
And when the voice is telling you, you must kill yourself. Okay. You have to do something. This life is not good for you. This is the end. Those are really the one that I am afraid. And then we need to help medically with medication, with medication in an inpatient hospital, but I'm always really hesitant, and I'm always very, very careful when I work with someone who hears voices and the message is kill yourself. So to go back to your question, it's depression. Yes, it's the most common one, but we don't have to think that if we lower depression, then automatically we lower the suicidal ideation, because a lot of times you help them with depression. And many times I got clients that say, Ennio, the depression is okay, it's under control, but I still think about suicide. What went wrong? You know? So.
I just want to bring about, a lot of borderline personality is associated with acts of suicide or, cutting themselves. Eating disorders is well associated. So what would you say about that?
Eating disorder is still somehow a debate if it is true that they starve to death because they want to kill themselves or is a consequence of the starving. So over there, we don't have a clear message. But some of them, they tell you, I'm starving to death, or I have to lose this weight. If I don't get to that weight, then I'm going to kill myself. Or in order to get to this unrealistic weight, there are consequences that physiologically speaking, they can be extreme consequences. The borderline personality disorder, really, we know a lot of the intervention by definition is the dialectical behavioral therapy, which is the best social theory, the idea that you have some kind of, and I agree with that. I think that some of us has a more of biological vulnerability to the emotions. There are some of us that they activate themselves in a second. And when I do the group, I'm like, okay, let's take this room. We are 10 of us. Let's divide this room. Let's put on the left the one that they go from 0 to 100 in 2 seconds. And they're like, yeah, I'm like this, I'm like this. And so they move on the left. And then I say, let's put on the right people who have more tolerance. And they go from 0 to 100. Will take you an hour. Will take you like 10 minutes, 15 minutes, and very few of them move towards right. So the idea is that this emotional dysregulation that we knew was involved into the non-suicidal self-induced behavior and the SIB, self-induced behavior, and the vulnerability, the fact that maybe you grew up in an environment that was not validating to you. You never had someone say, don't worry, I'm here for you. Don't worry, I can listen to you. You felt neglected. You felt rejected. Then what somehow gives out the consequences of having difficulties attaching to others, have these patterns of attachment that they are very disruptive. I don't trust you. I get too close to you. I get too far from you. I cannot manage my emotions. And in all of these big pictures, then suicide becomes a reality because you are overloaded, overcharged emotionally to the point that always within the terms of DBT, you cannot use your wise mind, which is a balance between the emotional mind and the thinking one, where sometimes you find some kind of solution of strategy. You are kidnapped by your emotion, and that's when it becomes very difficult to do an intervention. What do? Once again, we need to spend time to teach people new skills in order to lower this emotional activation. And DBT is very, very, very famous for this. It's very good. It's evidence-based, and they've done really an amazing job.
And that's my next question. So the outcome of the depression, can it be controlled?
That's a big question. Okay, let's look at the research. Some research says that you need a combination of psychotherapy and medications. That the best comma is given if you go psychotherapy. We know that some are, there's a lot of evidence for mostly cognitive behavioral therapy, which somehow has always been very specialized in dealing with people with depression. If you see the research at the Beck Institute, they have a very good data for the depression. On the other hand, there are, what do we say, the medications, right? So this combination. On the other hand, we don't have an extensive research when it comes even antidepressant. There is a lot of placebo effect. So it depends really who you ask this question. There are some people that will tell you we can control the outcomes of depression by giving medication, but we don't really have a solid research that shows that antidepressant work. And I am not saying that they don't work. First of all, I'm not a doctor, but I just read research. And really, what happens is, if you take a medication and they help you, we don't know, maybe it can just be a placebo effect, or actually the medication can help. So you continue to take the medication. We know that medication and therapy works. So they go well together, keep that. But the main idea is, we know, the lithium, it's one of the most researched anti-suicidal agents when we have a mood disorder. I think that is important, the motivation that you have to change and the expectancy that you have towards a treatment. But I believe that in the progression that I gave you before, from sadness to suicide, I think that somehow we have to help them. Call it depression, medication helps, psychotherapy helps, behavioral activation helps, sleeping better helps, eating healthy helps, whatever it helps. I would say lower your depression or makes you a little bit more functional that you can go through the day. Just do it. Do whatever works for you.
Okay, I want to come to a very difficult but a personal topic on, suicide being a sin. So we do know that in India, we, as a culture, as a nation, are very religious. There are various races and religions practiced all across India, and in probably most of them, suicide could be termed as a sin. And that you won't go, the karma, as it is called in Hinduism, so how does one deal with suicide being a sin? Because a family who's lost somebody to suicide is going to feel that, it was a wrong act, and, it's bestowed upon them, and now they have to rectify that in some way. And it's extremely traumatic in that sense.
It is traumatic, and you can't deny, like, you grew up in India, right? I
Yep.
grew up in Italy, then I moved to the States 20 years ago. But the idea is that there are some values and there are some roots and some way of thinking about religion that they stay with you. I grew up in an environment where, like you're saying, suicide was a sin.
Right. Is it a
And then
sin?
if you, huh?
I want you to answer the question. Is it a sin?
Now, I can't really answer these questions because I don't think I'm equipped enough and on the religious point of view. But as a clinician, I can say that what I have seen, that if you have and if you hold a very rigid idea that it
Right.
is a sin, and you truly believe that something happened to you, and just because it goes against your value, against your religion, and the fact that people kept giving you the same messages, it's a sin, it's a sin, it's a sin, I have seen that is very unhealthy for you.
Yep.
That becomes very unhealthy because it doesn't give you that degree of flexibility, of cognitive flexibility to understand that suicide is a phenomenon that happens. But the religion, I think that we have, I don't use religion in therapy. I tend to be more to use the word spiritual because in the
Right.
States, you know, there are a lot of religions. So I tend to say more like, do you have any practice that helps you? Can be a spiritual practice, can be mindfulness, can be religion. I try to have an idea about the background. We do know that there are some religions where this is forbidden. So
Right.
suicide is a no-no.
Right.
Christianity, Hinduism, Jewish religion, Islamism. Even though in the Hinduism, there are some, the idea is that you live well to die well. So it's mostly
Right.
based on the idea of living, but you have, I did some research, you have some phenomenon like, for example, sorry about the pronunciation, but it's called the sati,
Right. Yep.
right?
Yep. Yep.
Where there is a self-immolation. That's a form of suicide that sometimes it was accepted and is still practiced. Or
Right.
sometimes you have other phenomenon, even within a religion, such as the Jawar, which is a community of mass suicide after you were defeated by the Rajputs, how you
Yep.
say?
So the sati has been, of course, been is illegal right now. So in that form, it has been stopped
Yes.
completely. But the idea of suicide being a sin is so engraved, and like you said, looking at it from a spiritual angle.
Okay, let's take the spiritual angle and let's translate it a little bit in clinical terms. If it is a protective factors, if it is something that helps you, if it is something that connects you to people, if it is something that you feel that you belong to a community, if it is something that you are over there and you don't feel by yourself, if it is something that occupies your time, which means you are relating with other people, so you don't have time to get even more depressed, having negative thoughts,
Right.
using drugs or alcohol, then yes, it is a protective factors towards suicide. That's for sure. Some people like the idea that there is a higher power or that there is this authority on top of you that somehow will dictate your life.
Right.
We know that the research is clear. If you believe in something, you have a better quality of life. If you don't believe, that there is a good research that shows
Right.
that. So
Right.
in that case, people who believe, yes, can be a protective factors, yes. But then when you got the trigger that gets to you immediately, and then is like out of control, then I have, at least my experience, that a lot of times all these religious value, the protective factors, they go in they go in the corner. Because
Right.
no, now I have a crisis, now I really have to do something.
Yeah.
So I can't directly answer if it is a sin or not. I don't think I'm important enough, and I don't think I have enough knowledge to juggle between the clinical piece and the religious one. What I can say clinically is this: if the religion works for you, and if you believe that this is something that gives you more positive messages, which is a protective factors, then go
Then
for
you.
it.
Okay. And dealing with suicide also can be very overwhelming. And we can see, of course, like you said, there is a biological vulnerability as well. Post to suicide, I have seen, especially in the last year, where there have been an increase in rates of suicide in my country, that the stigma associated with suicide or the loss can be extremely devastating. How does one cope with this loss?
Yes. Some research in 2019 showed that as many as 135 people are affected when you are exposed to one suicide. So
Wow.
the fact that something happens, then there is also this effect to the people around you. And so
Right.
as much as you think, so as much
Did you
as you think is that in an isolated case, it really becomes a community case at times.
Right. And I just want to point out there, with the social media coming in right now, and it being on the media, on Instagram, on Twitter, I think, like you're saying, it is a much bigger community case.
Yes, it is amplified.
Yeah.
Like in the past, we know internet was happening in the small town, it was related to the small town. But
Right.
now something sensational happens, and then you develop what sometimes is called contagion effect, where people start to think, to see things, and if it happened, then it means that can happen to me.
Right.
If it happens in the family, I have a lot of clients that they tell me when I work with them, Ennio, the fact that my father did it, the fact that my mom did it, the fact that my brother did it, the fact that my sister or one of my cousins did it, it means I can do it.
Right.
So it gets very close to you. What is interesting based on what you're saying is that when we grow up, we always think suicide is not going to happen to me.
Right.
Suicide is not going to touch me. This is something that will touch you, but it's not going to be to me. I'm okay on this side. And this is really a misconception and the myth of suicide, because anyone feels suicidal sooner or later in life, and then is able to go through, have a good social support, and then it doesn't get to the point of develop a plan. But the idea is that the stigma, I think it becomes extreme because it's also related to this idea of mental illness. That something is wrong with you, that something is wrong in the family, that the family has done something that goes against the religion if you live in a place. As you said before, some people go to the healers and they don't go to people who are actually professional because they give a totally different value. But any value that you give and there is a stigma, it's because there is a judgmental factor that doesn't happen. And also because there are people that they say, oh, it's not going to happen to me, so it's your problem. And we are very good at judging each other. So at the end, they always will end up like, oh, look at what happened at the family. Now, the big problem with this is that once you have the stigma, not only the stigma, it can be dysfunctional to you, but has two really consequences. And the first one, it doesn't promote a healthy recovery.
Right.
And the second one is that can affect the treatment outcome. So which means not only you are judged for the tragedy that happened to you, but it's totally devastating to you. Then you have to deal with that. But you can't, because you are judged by people, because clinically you don't have a group that you can, like support groups sometimes where all the family, they get together. We don't have this reality in all of the country, or if you live in a very rural area. Okay, these days with the computer you can reach, but we know that the rural area, they don't have access to the computer. And so the idea is that you are left in a total isolation, devastated by something that happened and isolated by others. I have talked to parents that they tell me, Ennio, I have to cross the street and I have to on the other side, or people cross the street when they see me. It's like I have some kind of disease or some kind, I don't know what is happening with me.
Right. And also, I want to just point out the guilt, the family members tend to go into a lot of self-blame when there's been a death of suicide.
Why it happened to me? What did I do wrong? Automatically, I think that there is, the way we think about this is we elaborate and say, I did something wrong. And so you pay the consequences of something wrong that I did. If I am a parent, then automatically I say, I did something wrong. Maybe I didn't give enough education. Maybe that day I said no, that you wanted to go on vacation. And then since that day you didn't talk to me. We become very dysfunctional in try to find and pinpoint the reasons, and the question mark is going to be with you forever. Now, what happens is, and I think that the support group really needs to help towards acceptance. Sometimes there is not an answer or a clear answer like you would like to have. And so there has to be a degree of acceptance. Yes, it happened. Now, let's figure out together. Let's support each other. Let's figure out accepting this, how we can change and we can move on. But it becomes very, very dysfunctional, as you said, the guilt and the shame, mostly when some people say, if I don't have an answer for this big question mark, what happened to me, what happened to my son, what happened to my daughter, then they live the rest of their lives thinking that they did something wrong. And then you go back to, if there is a religious belief that it's a sin, that I did something wrong, that I'm not a good father, that I'm not a good mother. That's the reason why I think that we need more support groups. You have to find a way to help yourself, talk to people, and mostly talk to people who went through the same experience, because they can understand you and you can relate with them. And most of them, if not all of them, they are not judgmental because they have been through the same emotional turmoil that you have been through. And maybe they are asking themselves the same questions that you are asking. So connect with people if you can locally. Otherwise, I think that there are a lot of supports even all around the world.
Online, yeah.
Yeah,
Yeah.
online. Online is very good. Online, it can be bad. It can be great for resources. In this case, if you find a good group, I think it can be really amazing to connect with others.
So my last few question is primarily on, we have seen in India a few established people from the community, namely actors, we have lost them to suicide. There has been a lot of scandal in the media. There has not been a mockery on what depression is and why they were smiling a couple of days before the suicide. A lot of myths and themes that came out. And I want to just ask you, we've been coping with a lot of stigma associated with suicide. How does one change on a larger community level?
Okay, the message that arrives to you is a message that most of the time has been manipulated by the media, because they are looking for not to give you the right information or to follow the guidelines, because there are guidelines on how to present information. If you go on there was an official guidelines developed by I think it was the American Suicidology Association, if not the International Society of Suicide Prevention, where they gave us some kind of guidelines on how to present an information, what to do. Suicide sells well, unfortunately. And so when something happens, and the most thing, as you said, because I was kind of following in the past, there was an actor, an actress, that it happens really almost like one after another within like a few months span. And they were bombarding these people with, like, as you said, misinformation. It was related to depression. We cannot help people with depression. If you feel depressed, then you are going to end up to kill yourself. Drug was involved. Anytime you use the drug, something is going to happen. A lot of money. People have a lot of money. They are not happy. And then that's what happened with them. So what to do? It's very difficult to control the access to information, because let's suppose I tell you, Shraddha, don't watch TV, okay? Or you tell your kids, I say, okay, let me turn off the TV. As soon as they grab a cell phone, or you drive them to school, that is something that is showing this a sensational thing. So I think education is very important. Now, you cannot always have a proper education, because a lot of times depends on the source of information. Most of the time, when it becomes very, very sensational, or people romanticize what happened, it doesn't help. It doesn't give the right message. And that's why I think initiatives that they are community-based are very important. Having people like you who take these initiatives, or even make a video 2 or 3 minutes by saying, hello, this is happening in India. Those are the guidelines that we know that if we follow them are going to help us. So it is important to inform people, to reach the audience. It can be a community-based, if you live in a village, in a rural area, or like you, that you have, you're doing an amazing job. I've seen some of your videos that you can reach a lot of people. Will be make even 5 minutes. It doesn't have to be. And it doesn't have to be to show you how smart I am or smart you are. No, it's to reach people, that to say, this is dangerous. The way they are selling the news is dangerous, because they are putting certain things in your mind that they are unsupported by research, that they are not going to help in the long run. So Those are the guidelines. Let's talk about this.
Right. And so, like you said, on a community level, get more education on these norms, what guidelines need to follow. We still in a lockdown where schools haven't opened up. It's been more than a year plus. And I'm sort of concerned about the rates of teenage or children's suicide rising. So
Yeah.
what is your last message to kids, or to maybe parents, to guardians, to caretakers? Is there anything that they can do if the child expresses, like you said, do not dismiss the emotion. But, a lot of times in the shame and the stigma, we sort of miss saving the child. Uh, so what are some of your last messages to the audience?
I would say listen to your kids, number one. Number two, if they don't talk to you, because most of them don't, they spend a lot of time on the phone, video games, try to find some quality time, even if it's 5 or 10 minutes. But don't do that in a judgmental way. Just ask how they feel. Just ask what has been their experience throughout this pandemic. Understand what are the consequences. And try to ask the important questions. Do some progression in the future. Say, when all of this is, we hope that we have somehow out of control, you going back to your regular life. How do you feel about that? Try to understand, do they feel anxious about going back? Now, believe it or not, but there are a lot of kids that they are very, very happy to stay home because those
Right.
are kids that the other children make fun of them in school.
Yes.
And so they're like, oh, finally, I had the best year of my life. I was protected. No one is reaching me. And now they are terrified that they have to go back.
Right.
Some of them are very anxious to go back. Some
Yes.
of them have developed some form of depression and they don't want to connect with others. So the idea is to talk to them and try to figure out, what do you think is going to happen to you when you go back to school? Is there anything that is bothering you in particular? What do you think about everything happens? I know that this is something bigger than us and we don't know, but what are your thoughts? Talk to them. They are not stupid. Don't think that just because they're children, they are not able to tell you how they feel, that they are not able to put a sentence together, that they don't have a way of looking at things. That's
Right.
judgmental on our part. Just open your mind, open your heart, approach them, and have a serious conversation with them. And in a collaborative way, make sure that they understand that they can rely on you. Make sure that you tell them, don't worry, this is going to be very difficult for you. You are not going to be by yourself. We can keep talking about this. And if something happens, I am always here for you.
Right. And my last question is regarding schools. So if there has been a suicide in a school, what do you think the educational institution needs to do?
Schools, they have their protocols. There are some protocols and guidelines that sometimes they are individualized to different school, or sometimes can be more general guidelines. Once again, you have to check with your school if there is anything in place, or you can do a research. And I think the American Suicidology Association or the other Society for the Prevention, that they have a clear guidelines. You can ask your school what happens. And I think it is important, if in a preventive measure, you ask
Right.
your school what kind of policy they have in place. But once again, if there is a policy or if there is no policy where your kids go to school, you talk to your kids. It's simple. Even if they don't want to talk to you, try to negotiate 30 seconds, a minute, give them some reinforcement, special gelato or whatever. If we go, then try to reach them. Don't leave them by themselves. And even if they don't want to open the door, when you knock once, twice, I think after 20 or 30 times that you knock the door, they're like, okay, I need to talk to him just for a minute, otherwise it doesn't go away, or she doesn't go away. So they will address you. But don't give up, please. Just don't give up, because this is a serious matter.
Right.
So take this seriously.
I think, I'm going to end my talk with that very powerful message of don't give up. So thank you once again for being with us here, giving us extremely, extremely useful talk, psychoeducational policies, engaging with your kids. I think we got all of it. We're going to keep Dr. Ennio's details on our channel. Please reach out to him if you want to for any further questions or to us. Thank you.
Thank you for your amazing job. Thank you for having me. Big kiss to India. I hope to see you soon in person. And it's great. Keep doing what you're doing because this is amazing. Really, congratulations from my heart. Really, you're doing a great job. Great service.